Good evening, everybody. I would like to share with you my experience about working on OS4 by Earthly. I'm Karolina Zaczek-Zakrzewska, and I know it's hard to pronounce that. So please don't, just by the way of introduction, I'm not a very experienced surgeon, but nevertheless, I had an opportunity to work on a few different machines. I started phaco on DORC, then I proceed on Infinity by Alcon and Stellaris by Bausch, and now for 2 years, I work on OS4 by Earthly. And to be honest, for me, all these machines are well designed. They work as they should. They all have good and bad sides. So you may ask, why OS4? Well, for me, it's truly multifunctional machine. So you have this one machine and you can do cataract surgery, mini-invasive glaucoma surgery, and vitrectomy at the same time. Today I will talk only about glaucoma and cataract surgery. So let me start from cataract and how I changed the technique with OS4. As I said previously, the last machine I was working on was Stellaris by Bausch, and I was using 1.8 tip. I found it tiny, very delicate, satisfying, and very effective at the same time. So when I first used Earthly tip 2.2, 30 degrees angled, I just felt overwhelmed. I didn't know what to do with this. So I was doing some modifications, and I was listening carefully to one of the technicians, Mr. Mateusz Rakoczy. He's a technician from Consultronics, a Polish distributor of Earthly machines. And I realized that this bevel construction and the high vacuum settings will give me beautiful occlusion, and that gives me wonderful and strong holdability of the nucleus, so I can even use the tip as a rotator at the same time. So I changed the technique from bevel up to bevel on the sides and bevel down. And here we have the first film, the first video. I first do the first crack with bevel up, and then if I have a first crack, I try to move phaco tip to 1 o'clock. I get the nucleus, I catch the occlusion, and I chop. Sometimes I eat it, or I just move further to the right part of the nucleus. I chop it all the way through, and then I turn the bevel down just in order to eat all the fragments. And when I finished with this right part of nucleus, I try to rotate the bevel to 11 o'clock, not in this case, and eat the left part of the nucleus. So this way you can achieve a maximum cavitation and phaco energy into the nucleus. We can move further. That was a very hard case for me because it was wide, dense, post-traumatic, a little bit subluxated cataract with massive pseudo-exfoliated syndrome. I did the first crack. The pupil wasn't as wide as I would like it to be. I struggle a lot. I don't want to push too much. I don't want to, do the further subluxation, and I don't want to touch the iris. So I try to stay in one place and just rotate the bevel into 11 o'clock and chop the right part of the nucleus, and then bevel down to eat all the fragments. And now you can see how the nucleus is rotating by itself, right? I just catch it, get the occlusion, and the whole nucleus is rotated, so I can chop it and eat it. We can move to the next part, I think. This is another dense cataract, high myopic with unstable iris. And again, I'm trying to stay in one place just to avoid touching the iris. And if you stay in the middle, it's so much safer. So 1 o'clock, cut, occlude, and chop. And again and again. And then when I'm finished, I put the bevel down and eat all the fragments. And now bevel on 11 o'clock. And a little bit of rotation, and I chop. And again, the same way with bevel down. So all of that wouldn't be possible if I didn't perform the proper hydrodissection or hydrodelineation if the case allows, because these two are crucial for proper chopping. Otherwise, we will end up with this irritating bowl that I hate so much. So I try to remember to do this properly. And again, I do the first crock. And then I move to 1 o'clock position, and I chop the nucleus on the right. And again and again. I think this is enough, right? Okay. This bevel down solution is also good for me when I have a bad day in OR, because I don't know, sometimes either the nucleus is mean to me or I'm not in a good skill day, and I end up with this irritating looking like a daisy, partially chopped nucleus with the solid center. So then I turn the bevel down into this solid center, I catch the nucleus, I get the occlusion, I lift the nucleus, and I chop it all the way through with my left hand. As we are staying on cataract surgery, I would like to just say a few things about a very useful device, which is bipolar capsulotomy. And this is just a gentle alternative to Capsulorhexis, just because the tip doesn't cut or tear the capsular bag, but it evaporizes the tissues. So you can see a tip under the microscope. Of course, the surgeon can adjust energy levels on a OS4 touchscreen interface. You can do this in some hard cases, for example, dense cataract, wide cataract, traumatic or pediatric cataract, but also in capsular fibrosis and zonular weakness. But I also reach for the device if I struggle with very shallow anterior chamber, for example, in high hypermetropic eyes. And I simply have a better workspace with the tip than with Capsulorhexis forceps. This is the video of the capsulotomy. This is also the same wide, dense, post-traumatic, a little bit subluxated cataract that I've shown you before. This is the tip that evaporize the capsular bag. The bubbles you see are normal. And when you finished and you realize that you missed some spots, you can do it again in these places, or you can easily make it wider. Yeah, that's basically it. Then I use forceps to remove the capsular bag that I've got. And a few words about high-frequency deep sclerotomy. This is safe, mini-invasive glaucoma surgery. And what you see on this photo is platinum needle, which evaporize the tissues, and it can be heated in a very short time up to 130 degrees. So what surgeon does is 5 to 6 pockets through the trabecular meshwork into the Schlemm's canal and a little bit to the sclera. And the active time of the tip is about 1 second. So it evaporates the tissues but doesn't do any damage to the adherent structures. And that allows, of course, additional outflow of aqueous humor from anterior chamber to Schlemm's canal. So you create a pocket which is 1 millimeter deep. That's why it's so safe, because you cannot go through the whole sclera. And it's 0.3 millimeters high and 0.6 millimeters wide. The indications are quite wide, and it is mainly open-angle glaucoma, glaucoma due to pseudoexfoliative syndrome, and some others. I usually do high-frequency deep sclerotomy after cataract removal, and these are the steps of the procedure. So we will see it on the next slide. When I do cataract, I usually sit at 12 o'clock. When I do HFDS, I move to 3 or 9 o'clock, depending on the eye operated. So I sit at 3 or 9, and then the patient's head and microscope are rotated in opposite directions. So the head is rotated nasally, this is the left eye operated, and the microscope is rotated temporarily in order to achieve a good visualization of a nasal angle where I do HFDS. I use Swan-Jacobs gonioprism for visualization. And these are the steps on the video. So first I'd like to widen a little bit a temporal port, just in order to introduce HFDS safely. Then I put carbachol to constrict pupil. Then I put visco into the anterior chamber in order to maintain safe workspace for HFDS. Visco on the cornea. I introduce HFDS. And I apply gonioprism to visualize the angle, and I perform 5 to 6 pockets, although sometimes I do only 4, like in this case, and it still works. Yeah, I've changed the direction. Okay, and this is it. Short, safe, efficient procedure. Of course, there are some cases that you cannot perform HFDS, and these are mainly problems with angle visualization. Like in this case, this was high myopic eye, and I was a little bit confused. Yeah, the nurse gave me wrong tip. And then she gave me HFDS, so I was nervous, and I didn't expect that in high myopic eye, when I remove cataract and put IOL and put carbachol and visco, the whole peripheral iris will fold and cover the angle. So I tried to do first pocket with this pure visualization. I had a little bleeding occur. It stopped after 10 seconds, but I just gave up and didn't do any more pockets. As for complications, bleeding may occur, as I said, and sometimes you have to change the anesthesia, especially for those patients with low pain threshold. So I do it only in local anesthesia, but you can do it in peribulbar or subtenon. And after some time, after HFDS, you may see anterior synechia or local iris depigmentation. You should consider pilocarpine after the procedure, an antibiotic with steroids, just in order to avoid inflammation and anterior synechia. And this is my first case I did 2 years ago, and it was like an inspiration for me. It was like a biological trial, because it was 75 years old patient. He had glaucoma with PAX syndrome. He used 3 different anti-glaucoma eye drops. The IOP was 25 in the right eye, 23 in the left eye, and they were both ridiculously red, so he looked like a rabbit. And the right eye was already pseudophakic, so I thought it didn't help. So I just thought that maybe cataract removal with HFDS will do, and I was right. So after the procedure, he stopped using anti-glaucoma eye drops, and now he has beautiful white eye with no eye drops, and the pressure is still low, about 12. I also wanted to proceed the HFDS in the right eye, but he developed a massive herpetic iridocyclitis, so I didn't do that. These are my first cases with long-term results, and they're all fine after 2 years. So I hope for those of you who didn't do that yet, that you will start doing this, because in my opinion it's very useful device. It's mini-invasive, fast and very effective. So thank you very much for your attention.